great. Thank you very much indeed. So yes, talking about comfort, I felt distinctly uncomfortable being given this topic to talk about today. But that's really my problem, I think, and not yours. It's just no excuse for us not to talk about it. It just is certainly a difficult topic. Difficult to write a talk about, difficult perhaps to deliver, but I appreciate even more difficult to hear and to digest and really take on board some of the issues that are pertinent with respect to SUDEP, both really where we are now and going forward with a hope that things will improve in the future. So really my talk is entitled Past, Present and Future, so we'll cover a little bit about some of the historical background to SUDEP, but really concentrate much more about where we are today and hopefully where we're going in future. Certainly it's been the case that this talk is very much derived, I think, from the conversations that patients, relatives and carers have had with doctors subsequent to someone they've known suffering from SUDEP, about the information they'd like to know perhaps beforehand, which really, I think, as Colin's alluded to, really is missing in a large number of consultations. So that's really where my talk is based, is on really what I understand that you or others might want to know about SUDEP. But of course, there's always going to be time for questions at the end. I appreciate that this isn't a topic that everyone wants to know about. I think it's clear the vast majority perhaps do, but there are some, I'm sure, who will find this perhaps even more uncomfortable. And to those people, I do apologize, and I really mean no offense and discomfort to you by discussing it. But I hope I do so with enough sensitivity that I don't offend too many people. So first of all, a little historical background. SIDS, so that's sudden infant death syndrome. You'll be familiar with that. It's seen less commonly these days, but it's still one of the leading causes of death in the under 12-month old infants. There's a lot of similarities between SIDS and SUDEP. The occurrence of an unexplained death in a young child against unexplained death in someone with epilepsy. There's also some historical context to this as well. So SIDS was first described back in 1944 by Abramson, who noted that infants were dying with no clear explanation, but they were often found lying on their front, face down on the mattress. And he suggested this may be relevant in some respect. Further studies followed, and it was eventually fully defined in 1969. However, it was a study in Tasmania in the late 80s, early 90s, which really placed this idea that the prone position was really, that's face-down position, was really important in sudden infant death syndrome. So it was 47 years later that actually there were some interventions put in place. The UK, Australasia, and other continents really very much then started a national campaign to improve the risk of sudden infant death by reducing maternal smoking, placing babies on their back to sleep, and also avoiding overheating. And in this way, there was 30 to 40% of babies then were put on their backs to sleep, and there was a 70% reduction in SIDS over the next few years. So it took almost 50 years for the first indication that putting babies on their back to sleep was actually a good idea, to it really being a national campaign and making a difference. Now, if we then think about SUDEP, SUDEP was perhaps first described back in 1854, even earlier at that time. And again, it was noted that maybe there was something about lying on the patient's front, which was relevant, this prone position talked about in SIDS. Again, it was a number of years later, really, this was confirmed. It was really only in the 1990s that it was concluded that 60 to 70% of patients who succumbed to SUDEP were found in bed at night, lying on their front, with some evidence of a seizure having taken place. So that's 162 years later from its first being described that this may be a risk factor. Actually, we still don't have really very clear interventions in place. So I think this talk comes at a timely point, really, for us to really start translating some of what we know now into interventions to reduce the risk of SUDEP occurring. So on that historical background, really take it absolutely forward into the modern day. So this was a study that came out just this year, which said, what was the information that patients, relatives and carers wanted to know. And this, is, as I say, has led what I'm going to be talking about, that it's a rare occurrence, it's an uncommon occurrence, and that can be reassuring. Also look at some of the risk factors. What are those things that we know that make SUDEP a little more likely to occur? And what can we do about preventing it? Really, that's very much got to be the key message. So I'm sure you've seen a slide or something similar to this already. We can see that the incidence of epilepsy is highest in childhood, and then again with receding youth with cerebrovascular disease and other conditions. We see that about 30,000 patients develop epilepsy every year, and 5,000 die in the first year due to the underlying cause. That's dementia or strokes or tumours, this sort of thing. But we're interested really in that 1,000 that die as a direct result of epilepsy. 500 or so probably due to injuries and accidents, and 500 due to sudden unexpected death in epilepsy, SUDEP. Now, we've got to put that in the right framework. So we say 500 deaths in the UK. There are 50,000 to 100,000 deaths from sudden cardiac disease in the UK every year. So just putting that a little bit more into perspective. So what is SUDEP, the sudden unexpected death in epilepsy? It's a slightly clumsy definition, but it does work. It's about sudden unexpected, witnessed or unwitnessed, non-traumatic, non-drowning death in patients with epilepsy with or without evidence for a seizure, where there's no clear cause otherwise identified, and without status epilepticus, this condition of one seizure after another after another. So that's a definition of SUDEP. By definition, almost no other cause identified. If no other cause identified, then typically SUDEP would be diagnosed. So what actually is the risk? Well, if you just look at the general population itself, we put epilepsy to one side, I'm afraid we all have a risk of dying all the time. In the young, it's about 1 in 15,000 per year. Again, with receding youth, I'm afraid it goes up to 1 in 350 or so. But it's a sad fact to say that, unfortunately, 100% of us will die at some point in our lifetime, which is a really terrible statistic, I have to tell you about. But so where are we with respect to epilepsy? Well, for children, actually, the risk is increased, but it's really increased only slightly. Really 1 in 10,000 compared to that 1 in 15,000 we talked about for young adults without epilepsy. In young adults with epilepsy, then the risk is a little higher. It's 1 in 2 or 3,000 in the average patient with epilepsy that we'd see in clinic, up to 1 in 100, perhaps, with those patients who are really the very tough, challenging end of things, who perhaps are going forward for surgery or being turned down for surgery, where they're having recurrent convulsive seizures on a very regular basis. We're a little uncertain about the elderly on a number of fronts, but particularly in this aspect, because I think when, let's say, a post-mortem is conducted afterwards, there's always going to be some evidence of heart disease or some other abnormality, which then often will be attributed as the cause of death, rather than say, okay, well, that's not severe enough, it must have been SUDEP. So I suspect that there's a lot of difficulty establishing the correct underlying cause in the elderly group. So again, just putting this in some sort of context, we've got really a baseline. If you're a passenger in a car, and I think most of us are at some point, you've got a 1 in 5,000 chance of dying every year as a passenger in a car. You know, that's not too far off some of the risks that we're talking about here for epilepsy. Riding a motorcycle, so if you commute on a motorcycle, 1 in 1,000 annual risk. So again, you know, the risk, you know, I'm sure there's plenty of people here who would perhaps know someone or consider travelling in a car or riding a motorcycle and perhaps don't think about those risks associated. But certainly there are risks there. We know that hippos kill 2,900 people in Africa every year. It doesn't mean we're going to ban hippos, and I suspect the incidence is higher if they're on motorcycles. But it is amazing what you can find on the internet. 13 people are killed by vending machines. How does that happen? So, you know, it's about statistics, isn't it? It's about putting things in context. So we talked about where the risk is, and it's modest, it's there, and we need to talk about it, and it's the question is whether it's modifiable, whereas a lot of these other things aren't. And I think it's certainly empowering if one can modify risks and you're in charge rather than perhaps at the mercy of somebody else. A little bit like people much prefer to travel perhaps in their own transport, in a car or whatever, driving themselves, than have a fear about travelling in an aeroplane where the risk is actually much, much lower, but you're not in control. So there's definitely this sense of empowerment, which hopefully talks like this might provide us with some of that, really. Now, just to put this in some more visual context, a bit of a Specsaver slide, I apologise for that. But this is the number of people that die in the UK every year. About 500,000 here in the middle will die every year. My thing doesn't work, but nevertheless, so 500,000. So how does that split up? Well, the top group up there, you can see the big area of red there is about heart disease. So lots of people die of heart disease. At the bottom down here in the green, we've got cancer. So a lot of people are dying of heart disease and cancers, as you might expect. Now, anyone spot epilepsy on that? Well, I'll show you. My pointer doesn't work, but I'll have to wander. It's this little one here. Okay, so this is neurology, and there's epilepsy. little tiny dot there. Okay, so that's putting it much more visually in context, really, of where the risk lies. That's all the deaths in the UK every year, and that dot over there represents deaths due to epilepsy, which is smaller than Alzheimer's, smaller than Parkinson's disease, smaller than motor neuron disease, lots of other conditions that we come across as well. So just visually, that's where I think I would place really the conversation that we're having today. But the risk is there, so let's talk about that in a little bit more detail. The bottom end here and the bottom left, these are patients whose seizures are very well controlled. The risk is very low, 1 in 2 or 3,000. Very low risk, akin to travelling in a car, that sort of thing. The other end of the spectrum, up on the right-hand side here with the blue bars, this is the group which are really having seizures all the time despite our best efforts, despite maybe having surgery or being on lots of different medications, as we heard from Professor Sander earlier on. These are still patients who continue to have seizures. The risk is up to 1 in 100, 1 in 200 every year. So who is most at risk? What are the real risk factors that we need to be thinking about here that we may be able to modify? It's all really about convulsive seizures. That's the biggest risk. So having brief, complex partial seizures, lapses in awareness, or funny feelings, or little jerks, or blank spells, actually the risk is very little as a result of those. It's the convulsions, particularly nighttime episodes, and particularly when they happen with the patient on their own at night. So those are the real key aspects. And that's really what drives me, certainly in clinic, to really push extremely hard to get better seizure controls when I hear about convulsions still ongoing. Clearly, I still work extremely hard, and half the audience, I think, is my patients, actually. So yeah, I promise I work hard anyway. But, that is absolutely a red flag in my mind to really make sure things settle as best we can. Certainly, younger adults seem to be more susceptible. Again, this could be just bias. We're not sure, again, with the elderly population, if we're looking at SUDEP or something else. But certainly it's the case in about 3/4 of the studies that have been undertaken, patients under the age of 45 years old. There could be a behavioural aspect, of course, people heading off to university, maybe perhaps not looking after themselves quite so well, not taking their medication, or I understand sometimes people drink alcohol. So those sorts of things may influence that risk in the younger age group, like myself. So the duration of epilepsy is important. I think perhaps it's because that's the length of time that people have had epilepsy for. The longer you've had epilepsy, the more seizures you've had, the more risk has accumulated. It's possible that's the cause, or it could be another unknown factor that we don't know. Other risk factors which people talk about, but actually there's much less evidence for, is that males are more susceptible than females. Again, could this be behavioural? Could it be just something more inherent within men that makes us more likely to experience SUDEP? Low levels of drugs, I think that's clear that actually patients who don't take their medications, or who perhaps take them intermittently, or if the dosing isn't right, certainly are at greater risk of SUDEP. I think it's a modest increased risk, but it's a bit of a marker, certainly. So I'm always encouraging my patients to take their medications really to not only to improve their seizures, but really to make sure that they're as safe as possible with respect to SUDEP. I'm sure you'll have heard from Professor Sisodi either today or another time, and I wouldn't want to steal his thunder, but there may be genetic factors which are also at play, and some gene makeups in some conditions confer additional risk. And I won't go into that, and that's a whole talk in itself. There are some things which aren't risk factors, which are often suggested that they are. So a particular drug, lamotrigine and carbamazepine, have been suggested in the past that these are drugs making patients more likely to develop SUDEP. Really, this isn't the case at all. They're just two common drugs, therefore overrepresented in the population who have SUDEP. But there's lots of discussion around it, but it really hasn't been borne out that those are any more risky drugs than anything else. Patients with intellectual disability, psychiatric illness, mood disturbance, depression, etc., or any brain lesion, no more at greater risk than anybody else. So it can be generally reassuring news. So the risk factors, really, just to sum up, would be typically those convulsive seizures happening at night in someone who's living on their own, possibly a young male, but really I wouldn't want to exclude anyone else at this stage. So how can we judge risk? How can we quantify what that risk might be? Well, we can use a number of different tools that are there. Now, clearly, if you've got this information to hand, you don't need additional tools or checklists or apps or this sort of thing, but they can be helpful, particularly in the more widespread general neurology clinics. So a checklist can be helpful just to tell really which are the risk factors that patients have got, which aren't important, which are, and there can be just a simple tick box that you can count up the number of ticks you've got and work out what the risks are. And then what's important is work out which ones you can modify, which ones can actually be changed. You can't do too much about being male. I guess. Yeah, that's another talk in itself, I suspect. And you can't do too much about when your epilepsy started, but certainly we can modify really best we can how often seizures occur, what type of seizures, what type of medications, making sure that they're well suited and that you're able to take them without any significant side effects, which would discourage medication compliance, let's put it that way. These are now available as an Excel spreadsheet through SUDEP Action website, so it's very easy to use, and it comes up with a score at the end of risk. And as I said, some of these are modifiable, but a lot are static and can't be changed. Moving with the times, there's certainly some apps now available on mobile phones, so you can put in certain parameters about your epilepsy and yourself. It'll come out with some risks and where you may be able to modify things to improve. So this is EPSMON, Epilepsy Self-Monitor app that's now available. It's a winner of the Epilepsy Foundation SUDEP Institute, sort of looking at exactly these sorts of very patient-friendly risk monitor strategies. And I think it's very easy to use, and we'll give some advice. You can see on the example here it says, book an epilepsy review with your GP. That's perhaps easier said than done, I think, sometimes. But it may say, book an appointment with your consultant, or please take your tablets, or it may do something along those lines. But it can be very helpful in just looking at some of those risk factors and how, again, one can modify those. It really puts it just at the forefront. So I think there's going to be more and more of these emerging technologies over time, which really, again, is just another vehicle to empower patients and their relatives about managing the epilepsy successfully. So, a little bit about what causes SUDEP. I think it's fair to say we don't actually know. We've learnt a lot, for sure, but we don't actually know. We think it's something clearly to do with cardiac function, breathing, and brain rhythms. The brain is intimately connected to, of course, your heart and lungs through really a whole network of nerve fibers that we can see coursing down through the brain, down towards the brainstem in this region here. And the lower region, the brainstem, looks after our breathing and our heart rate. And so you can see all the wiring from the rest of the brain leads all down to that brainstem, and that's why there's just such an intimate relationship between seizures and that function at the brainstem level. From a more schematic point of view, the brain is denoted sort of in the green up at the top, the brainstem in the purple circle in the middle. And through its various feedbacks and various wirings, that leads to cardiac and respiratory changes. So we can see that during most seizures, heart rate would increase. 90% of the time during a seizure, heart rate goes up. It could be the physical activity, of course, of a seizure, or it could just be the messages going down the wiring to the heart, which makes it speed up. Very occasionally, less than maybe 5% of the recorded seizures that we see, but far less than that in reality, I'm sure. We can see the heart slow down briefly, or even stop or pause for a few seconds. That's called bradycardia or asystole. So I did a study with the rest of the group at Queen Square, implanting some of these long-term ECG recorders just under the skin and the left side of the chest wall. That monitors the heart rate over 18 months. And that can record what happens to the heart rate when patients are having seizures or in between. And we found that actually a reasonable proportion of patients with really very challenging epilepsy are having little pauses every now and again with their seizures. The heart rate on each occasion, of course, just restarts again. And we don't know whether that's a bad thing. Intuitively, you'd think it would be, but actually it may not be. It may be that always the heart starts again, and actually it's nothing to do with it. But again, you just think, well, if the heart's pausing briefly sometimes with seizures, very rarely, but sometimes it does, then is that something to do with SUDEP? Intuitively, you think it must be, but I think the jury, again, is still out on that. So these are the sort of tracings that we sometimes saw. So the heart rate, you can see just beating along, and then suddenly there'll be little pauses where then the heart rate would then just suddenly stop for a few seconds. Then the heart would start again, and then we'd pick this up at a later point. We put a few pacemakers in these patients, not really sure what else we should be doing. We follow them up over time, and everyone has been fine. But again, just think, is this some marker of perhaps what's happening with SUDEP, with the heart briefly pausing, and then, unfortunately, perhaps not starting again? No real evidence of that, but nevertheless, it needs to be thought about. What about breathing? It's possible that breathing is more of an issue with respect to seizures. We know that during seizures, patients can cough and hyperventilate, and I'm sure you're aware of some of the challenges, the difficulty patients have got with breathing. Not only the actual breathing mechanism of sometimes appearing noisy and obstructed, but also we know with affecting the brainstem, but that will also slow down breathing and reduce the oxygen levels in the blood to sometimes just a little bit less than 90% or so. We all trickle along about 95, 96%, so it just drops a little bit, significantly so, but drops. It lasts 30 to 60 seconds and then regains where it was before. So again, a bit of a marker that when patients having seizures, the heart can slow down and stop sometimes for a few seconds. The breathing can also be affected as well. So you kind of think this must be something to do with SUDEP. But again, the jury is a little out on exactly what the mechanisms could be. And finally, could it just be the brain itself rather than nothing to do with the heart and the breathing? And certainly we do see this rather busy EEG. This is a brainwave picture, really. And that shows that on the top bar where it says number 1, the brainwave activity just stops on the left-hand side of the brain, and then a few seconds later, it just stops on the right-hand side of the brain. And the heart and the breathing is still going on for a period of time after that. So we think it's breathing. Is it heart, or is it the brain itself, or is it most likely a combination of perhaps all of these things that are going on? So we need to really put all our efforts into looking at all these aspects and think how we might address them. There's been a very important study done very recently, and they looked at patients who had unfortunately succumbed to SUDEP whilst being monitored in one of the video telemetry units around the world. So it still happens even when patients are being monitored in hospital on a video camera with nursing staff nearby. They found at least 10 cases where there was this data of heart and breathing. And they found that certainly the typical picture was that a seizure, a convulsion would start. There'd be rapid breathing, maybe for a minute or so. And then there'd be 3 minutes or so of perhaps where the breathing and the heart would just slow down a little bit after the seizure had finished. And then sometimes that would recur 10, 12, 11 minutes later on. So the bottom line is that it's important to intervene within the first few minutes to stimulate breathing and heart going again. We know that intervention here, stimulation after seizures, is important to get the heart and the breathing going again. So I think that's an important message of what we can do with SUDEP. But also then I would say monitor then closely for another 10, 15 minutes, because sometimes those aspects can take a bit of a dip again at that time. So really it's about intervention with stimulation within the first few minutes, and then keeping that going, making sure the patient's really fully recovered for the full 15, 20 minutes or so after that. So without wanting to worry you too much, this information is extremely valuable in just thinking about what the mechanisms are behind what's going on. And these things are then best placed to inform us about how we're going to deal with them. Because at the end of the day, it's all about management. Is this actually preventable? So the first suggestion that actually that it is more preventable than we thought came from this really important landmark paper in 2002 from Jane Hanna of SUDEP Action and our own Professor Sander. This is about an audit of epilepsy-related death entitled Epilepsy, Death in the Shadows. It was a really pivotal study which showed that up to 40% of adult deaths were considered to be potentially or probably avoidable. And you won't better read it probably from where you are. But the things that they picked up were aspects such as inadequate drug management, perhaps the wrong dosing strategy, not being seen more frequently in the clinics, not having enough investigations to establish the underlying cause, one or two more major errors possibly as well. So up to 40% were deemed to be potentially preventable. So I think it absolutely drives us on then to think, well, in what way can we prevent what's going on? Well, the first step is clearly to identify who's at risk. And we've talked a little bit about some of those risk assessment tools, the apps, the monitors, the checklists. It's really to see if we can identify patients who are at risk from what the risk factors that we know. But what about risk factors that we don't know? What about biomarkers and genetics? What I mean by that is, could you do an ECG, a heart rate tracing on someone in clinic, examine it very carefully and see whether that patient is therefore at risk more than anybody else of developing SUDEP at some point. Look at their EEG patterns to see again whether there's some pattern there, subtle pattern that we haven't seen before that may provide some sort of marker for their risk to be there. And we don't know that yet. And similarly with genetics. Again, I'm sure Professor Sodi has told you about this or will do at some point, but there may be some genes that just modify our risk of developing SUDEP. So could we put all of this together, look at people's biomarkers, their genetic makeup, some of those risk factors we're already aware of, identifying those at greatest risk, and then keeping a register of those patients so that we can then really target the research and target interventions to this higher risk group, and then we're more likely to then help those greatest at risk, but also establish the information much more quickly about what we can then apply to the wider population. So I think it's important to identify patients at risk, and then it's important to modify those risk factors. Professor Sander, I'm sure, has told you about really improving seizure control with medication. Yeah, it's clearly vital. There isn't really a place anymore for us just to say, well, you've tried 5 or 6 drugs, let's not try the 7th, 8th, 9th, 10th. I've certainly had patients who've been on their 15th drug where suddenly everything has got better and seizures have stopped, and it's made an enormous difference to their quality of life. So, my motto in clinic, I think, as much as the rest of Queen Square is, never give up. That's really absolutely the case. And if the drugs aren't working, there are sometimes other options. There's surgery, there's dietary manipulation, there's vagal nerve stimulators, there's lots of other things that should be discussed. It isn't all just about medication. About addressing some of those triggers, there's things that you can do as well in terms of getting an adequate night's sleep, taking the medication, not drinking too much, all those risk factors that for some patients are relevant, but not for everybody. And improving compliance, as I say. There was an interesting study a number of years ago which showed that in the trials of some of the medications that have been undertaken, if patients were in the placebo arm, that is, taking the dummy pill, then they were 7 or 8 times more likely to develop SUDEP than if they were in the active arm, taking the active medication that was on trial. Suggesting that actually if you do nothing, then what we are doing is putting patients at risk, whereas we need to keep trying the next therapy, the next treatment, so that we can really reduce the risk as much as possible. It really isn't an option to do nothing. So back to, is it preventable? What about some of these alarms, monitors, and supervision? I'm sure you've heard a lot about these, and to be honest, you probably know more about these than I do. Movement sensors, pressure mat under the bed. Good detection rate, but I'm sure anyone who uses them knows that there's a high false positive rate. They can go off all the time, and once they've gone off 5 or 6 times every night, people switch them off, and then they're useless. They're just a decoration, really. So you need that combination of, yes, it's able to pick up the seizures, but it's also not picking up things that aren't seizures, so that the alarm isn't going off continuously. A bit like that car alarm up the road that's always going off. That's the car to steal, isn't it? Because no one ever looks out the window when they hear that same car alarm going off. Everyone's ignoring it. So it's about really the false positive rate is really key. But they're simple, they're easy to use, they're available. Accelerometers, so these are devices that will measure the speed of movement, change of movement in different directions. Again, with better technology, the iWatch has got some new apps out which enable really movement to be tracked. And they're bringing that out, actually, not just for movement in terms of a sport application, but also one for epilepsy as well. There's, again, good detection rate, but again, high false positive rate because of just other movements triggering off the alarm. But certainly this is an area to watch, these smartphones and these watches. Of course, you could just sit in the room watching the patient or with it on a video camera the whole time. This is rather impractical, intrusive, but undoubtedly is protective, and we know that. Having someone over the age of 12 in your room with you at night is apparently protective of the seizure. Under the age of 12, apparently doesn't count. I'm not quite sure what an 11-year-old would deem an 11-year-old would do, but I'm sure there's many mature, younger helpers out there who are equally able to summon assistance or stimulate the patient. Nevertheless, largely impractical and really very intrusive in terms of privacy for an individual patient as well. So really we need to think about other methods rather than just video or having someone in the room. Could we measure other parameters? We know that with seizures, increased sweating, heart rate, and we talked about in some of those breathing aspects. I think it's likely to be some of the technology is going to be a combination of all of these things, measuring them at different times, seeing if there's a certain parameters that will classify a seizure and identify it as a seizure that's happening and trigger an alarm. We're looking at something called the WAD, which is the Wearable Apnea Detection Device. This is something that we're developing at Queen Square with partners at the Imperial College. And that's a little device that just gets stuck to the front of the throat here, and that listens to the passage of air going up and down through the trachea, the breathing tube in the neck. And if then there's a pause in that, then it triggers an alarm. That's certainly very sensitive, and there's a very low false positive rate as well. So I think watch this space that may well be on the market. It doesn't do anything, however, at the moment to monitor heart rate or other aspects, just breathing. So it's perhaps leaving something exposed there. The new vagal nerve stimulators also measure heart rate at the same time now as well, so they can add a little burst of activity to the VNS when they detect the heart rate increase as a marker of a seizure. So it wouldn't surprise me if there's further developments of this in terms of alarms over time. Electromyography, this is measuring muscle movement, so particular patterns of muscle movement with electrodes on certain muscles could indicate a seizure is happening. There's no home device available at the present time, although some may be in development. good detection rate and very few false positives. So again, I think it's likely this is going to be a watch this space as well. So as you can see, there's really no really individual alarm or monitor that really does the whole job, and I think it's a matter sometimes of trying different ones and seeing, but it's choosing who to try it on is what's very difficult, and so therefore those with convulsive nocturnal seizures would tend to be the group I think I would tend to recommend it for. Maybe all what we need is a dog. So perhaps not that one, that looks far too cute, but so seizure alert dog. So high detection rate, picks up seizures. I don't know if anyone has a seizure alert dog, but high detection rate. Also quite good at picking up other things too, non-epileptic attacks or someone at the front door or whoever else. So, you have to be slightly careful that they're always detecting what you think they are. And sometimes they only detect it actually after the seizures really started. And that's really what you want. You want something, dog's able to detect it right before things start, able to get to a position of safety or alert others to the seizure happening. What's interesting, however, is even if you just have a seizure alert dog, your seizure frequency tends to go down, probably because some quality of life aspect, much calmer, more relaxed. So having a dog seems like a good idea for a number of reasons, doesn't it, really? I don't want that to be my take-home message, just make that really clear. But nevertheless, I just put it in there, I guess. So what about other things? So interventions, medications, and non-pharmacological aspects. What about, are there any drugs, not epilepsy drugs, but are there any other drugs that may be helpful here? Well, there's some evidence to suggest that serotonin, which is 5-HT, is an important neurotransmitter in the brain, which is released when our carbon dioxide levels go up. So that's when we're not breathing adequately, carbon dioxide levels go up, and serotonin is supposed to stimulate our breathing again. They've looked at a number of mice models looking at this and established that in those who don't have proper 5-HT working, those mice are much more susceptible to breathing difficulties after seizures. And then they're given a drug which enhances 5-HT, and their breathing actually is fine after seizures. And that drug is not an unusual drug, it's Prozac. So they give these mice Prozac, and their breathing actually is fine when they have seizures. So there's a study going on looking at some of these drugs, the SSRI antidepressant medications, to see whether they actually can help to prevent the breathing difficulties we see. And certainly in patients have seen really that there's been less problems with breathing and oxygen levels after seizures in the context of having some of these medications. So medications already out there, which are safe in epilepsy, which some people already take, they may be actually preventative for us. Other drugs, other neurotransmitters are important. Adenosines released after seizures, which are thought to inhibit the seizure activity and the body's own natural way of settling a seizure, but also inhibits brainstem function, makes breathing and heart rate a little less likely. Caffeine blocks the action of adenosine. As well, endogenous opioids are released during seizures, so these are the body's own mechanism, again, of stopping seizures. So naloxone, a well-used antidote to opioid overdoses, can be used as well. So I'm not suggesting that we all head off to Starbucks for a double espresso with an extra shot of Prozac, but you can see that these are interesting times, because these studies are now ongoing, and it will be interesting to see actually for the first time whether some of these can translate into modifiable preventions. What about other things? Well, we could put pacemakers in people to support the heart. We could perhaps put other devices in heads to really stop seizures happening or stimulate brain and breathing function in the brainstem. I think those are really very unproven technologies. Oxygen therapy really is having oxygen at home. Is that preventative? Is that safe at all? Well, as the jury's out on that one, I think there's no good evidence that giving oxygen during or after seizures can help prevent SUDEP. And similarly with those pillows, anti-suffocation pillows, which really will help to reduce the problems with breathing during seizure. Again, we just don't know. There's no data out there yet showing that they are safe. But these are things that all people talk about and try. So finally, just a little note about some education and discussion. The NICE guidelines are very clear about what we should be telling patients. We should be really talking about SUDEP to all patients who have epilepsy, including literature really about a wide educational program. It should be tailored to that person's individual circumstances, not just given as a blanket, here's the information about SUDEP. That should be really very much focused on the individual in front of us. We should talk about what can minimize SUDEP, and we've talked a little bit about some of those things today, and tailor that discussion, as I say, really to take account of the small but definite risk of SUDEP that we've got. So we asked a load of UK neurologists, do you talk about SUDEP with your patients? And less than 5% discussed it always, 25% discussed it majority, and 61% discussed it very few patients. and 7% never discussed it at all. So despite those nice guidelines and everything we've talked about, actually what's happening out in the real world is that SUDEP isn't being discussed. This is again seen in the States. They looked at our 17,000 neurologists and got a very poor response from them. But generally speaking, 11% never discussed SUDEP. The neurologists were much more likely to discuss SUDEP if they'd had a patient who had succumbed to SUDEP, or if they had lots of patients they looked after with epilepsy. So those are the clinicians that tended to think it was important to talk about it. So the Australian group, however, countered this and said, well, there's no real clear modifiable risk factor. We talked about things that we can do, but they said, well, there's nothing really that's very modifiable there. A failure to discuss actually isn't negligent, and, every patient has a right not to know. So the warning of a possible outcome for there is no intervention may contravene the basic medical and ethical principles of do no harm. So they said maybe we're doing more harm by talking about it and increasing people's levels of stress rather than not. So I think in terms of the pros of discussion, it should be, the advantage of discussing in clinic is it's in a controlled environment. You can make sure the information is accurate. It's not got from Dr. Google, who sometimes is not the best source of information, I find. It's an open and honest approach, opportunity to ask questions, interact really about some of those issues. And I think we know that it can aid compliance and modified behavior. But some people would say, well, okay, you can't prevent it, so why talk about it? It's unnecessarily stressful and worrisome. And it's a quality of life issues and this negligence aspect. But every patient has a right to know the full consequence of their illness, and it should always be discussed. Or should there be knowledge of what the clinical facts mean is not always the priceless resource other writers suggest. Sometimes it is too threatening. So flip sides to both of the coin there. What I think is the potential risk should be disclosed in the context of a comprehensive educational program. It's really part of the whole education aspect of epilepsy. The risk of SUDEP needs to be emphasized sometimes to encourage compliance. So, really drum home the message if really patients really aren't engaging with their treatment, and really imploring them to do so. Recognize the risk is low for patients. This can be reassuring. The timing of the information should be, carefully timed, should be individualized, judging when that time is right to have that conversation without giving information overload. Lots of ways of giving the information, and as I say, it should be part of a program. So in summary, what I would like my patients to do, take your medication regularly and reliably, and I'm aware that not everyone does. Keep regular appointments. Consider using a diary or perhaps smartphone to monitor epilepsy, so it's useful to see where we're going with the seizures and medications. Don't adjust your medication ideally or stop taking it, certainly without us discussing it beforehand, and talk about things with your friends or relatives. Explain what they should do if you have a seizure, to go back to that stimulation afterwards, up to that 12, 13 minutes after a seizure. Look at those triggers and see if we can cut those down and prevent the seizures from occurring. And we should always be discussing other treatment options. If it's not medicines, what about surgery? What about all those other aspects which can be helpful? And if any circumstances change, like I want to start a family, or I want to come off my medication, or I'm changing job, or I've had some problems, then again, always speak to a health professional there. So a final word. So I think we're on the threshold of a new era in SUDEP research. There is no place anymore for this nihilistic approach of let's do nothing, even though we know some of these risk factors are out there. How can we be reasonably confident about this? Well, we know that most SUDEP deaths now, instead of suggestion of, I think it's clear that most SUDEP deaths do follow convulsive seizures, and they can be reduced by treatment changes and lifestyle modifications. So that's definitely something that we can do. We know with evidence that supervision is at least in some part protective, and that really some developments over time with technology in terms of the seizure and apnea detection devices, they'll certainly enable prompt intervention, which I think then will translate into an improvement in SUDEP rates. We also have a better understanding of what's going on with the brain, the heart, and the brain waves. But as I've alluded to, we don't have the full picture yet, and I think this will be interesting over the next few years where this is going. We talked about interventions, really, simple measures, repositioning, stimulation, but also preventative medications, the Prozacs and the other drugs out there which are under trial at the moment to see whether they will actually prove to be beneficial. And there are always more options. There are more options than ever to treat epilepsy, so it isn't an option to do nothing. So what are my challenges? Well, we need to better understand the risk factors, look at those biomarkers, the genetic predispositions, better identify those at risk so we can really target these prevention strategies much more effective than we've done already. We need to clarify the roles of simple interventions, more sophisticated interventions, and we need to accurately monitor the SUDEP incidence in defined populations with registries so that we really have a very good idea of how these risk factors play out and what interventions are making a difference. We need to involve patients, relatives, the carers, and no doubt about that at all. I think that's really borne out with all aspects of SUDEP research. But most importantly, we need to educate to protect. We need to educate everybody, ourselves, other neurologists, other doctors, carers, patients, relatives. There's no doubt that education, I think, in SUDEP research is protective. And you'll be pleased to know I'll leave it there. Thanks very much.